So it's my honor to introduce us to the next presenters. Susan Bronskill is a senior scientist and scientific lead of the Life Stages Research Program at ICES and a professor in the Institute of Health Policy, Management and Evaluation of the Dalla Lana School of Public Health at the University of Toronto. Dr. Bronskill leads ONDRI's Aim 4. And then Laura Maclagan is a senior epidemiologist at ICES, where she designs, analyzes, and reports on health services research studies using large administrative databases. Laura is the portfolio manager for ONDRI's Aim 4, our health services area that will be discussed right now.
Thank you, Ruth. We're delighted to talk to everybody today. And what we're going to end up doing is a lot of what we've talked about so far today is focused on research on individuals. So taking individual measurements from people, whether they be clinical or sensors or things like that. What we're going to do is take the higher view, and we're going to think about how we characterize all 200,000 persons living with dementia in Ontario. So next slide, please, Laura. And the technique or the research tools that we use to do this are a type of data called health administrative data. And so what we're going to do in our presentation is talk to you all a little bit about what these data are and why they're useful for research. I'll do that part. And then Laura is going to share some research findings from 3 studies that we've recently completed, so you can get a sense of how the data are used in action. And then we'll have a few takeaway messages. We'll tie this into how the health administrative data are going to be used in the HAANDS-Ontario study that you've heard mentioned a lot today. And we actually have a few questions for you, although we're tight on time, so maybe we'll wait until all the presenters have gone. So when we're talking about health administrative data, we're talking about data that are generated by governments and other organizations for healthcare billing, record keeping, and evaluation. So you can think of this as in Ontario, each time you go to see a physician, you visit the emergency department, you have a drug prescription filled, that can be considered a health system encounter, and there's a record of that health system encounter. And those healthcare system encounters exist for nearly all 14 million Ontarians. And so what we do as researchers is we're able to use these data and link them across people in a de-identified privacy protected setting. And that lets us conduct studies on populations and how populations use health services. Next slide. And we do this at an organization called ICES. And this is a little video that's just going to describe health administrative data and for you.
Since 1992, ICES has been working behind the scenes to improve Ontario's healthcare system and the health of the people of Ontario. How do we do all this? Let's break it down a bit. The Ontario government collects routine information about healthcare system use so it can plan, administer, and pay for health services. All this information is called administrative data. A new piece of administrative data is created every time someone has an interaction with the healthcare system. Whether it's a visit to the doctor, a prescription being filled, or a hospital admission, every piece of information is important. Usually, this data is stored in separate databases, but the real power of administrative data comes when we link them together to create a big picture of healthcare patterns and trends over time and across Ontario. Linking the data lets us look deeper, way beyond the individual picture. It allows us to identify problems and evaluate potential solutions that will improve healthcare for the whole population. We go to great lengths to protect this important data and the public's privacy. In fact, the first thing we do is to remove names from the data before it is used for research. Through our innovative use of administrative data, ICES generates powerful evidence that is used in the planning and evaluation of Ontario's health system, evidence that supports better policy, a stronger healthcare system, and healthier people.
So I find that video manages to present the concept of health administrative data much more eloquently than I can do on my own. So hopefully that was helpful to people. We talk about ICES, the video talks about ICES. So that's an independent, not-for-profit research institute where our core funding comes from the Ontario Ministries of Health and Ministry of Long-Term Care. Many other organizations have access to the data as well, sometimes in different forms. So the Ministry of Health itself uses the data for analyses. Many of you might have heard of the organization CIHI, which collects a lot of the emergency department and hospitalization data initially. So we're just one player in the system of who uses data. We're a community of research and data, as well as clinical experts. And we have a secure array of Ontario's health-related data. So the core of our data are the administrative data, but there are a lot of studies that happen that use electronic medical record data, population-based health social survey data, clinical cohorts get brought in and linked to the data. So the HANDS Ontario study would be an example of that. And we're an Ontario-wide network. So the picture you see here is our building on the grounds of Sunnybrook Hospital. Those of you who live in Toronto may have driven down the hill behind Sunnybrook to go and walk your dogs at the dog park that's down there. That's us on your left as you're driving down the hill. But we also have sites at all of Ontario's medical schools, and they're listed there. Next slide, please, Laura. Oh, back one, yeah. So I think you saw Mario present this schematic earlier in terms of the different aims of ONDRI. And so we connect in with aim 4, which is here in the bottom left. And we're really focused on analyzing the health system records to inform healthcare policy and planning. In consultation with members of ONDRI's patient and health partner community, we identified some key themes where we wanted to anchor our ONDRI Aim 4 research. And they're listed here. So we have conducted a number of studies looking at health system use and cost of services across settings. We have a theme that focuses on multimorbidity. So obviously individual conditions like dementia don't occur by themselves. They frequently occur with diabetes, with Parkinson's disease, with other sorts of conditions. And so we have a series of studies that looks at characterizing this multimorbidity, but also thinking about what kind of health system multidisciplinary approaches are needed to address them. We have a series of studies looking at medication use. Obviously, there are some dementia-specific medications, but also medications that are used in older adults more broadly. And then we're also very interested in trying to think about how to extend the administrative data with rich clinical cohorts, with electronic medical record information and other kinds of studies. So the examples that Laura is going to talk about today fit into each of these themes. So she's going to present you some findings from one of our recent studies looking at the impact of COVID-19 and health service use in persons with dementia and Parkinson's disease. She's going to share some findings where we look at what other conditions co-occur and the sequence of that co-occurrence with dementia. And she's also going to share some findings on sex differences in how antipsychotics and benzodiazepines are used in the long-term care environment. And finally, just briefly, she's going to touch on how we connect the health administrative data into the HANDS Ontario research study. So over to you, Laura.
Thanks so much, Susan. Hopefully you can hear me.
You're a little bit quiet.
Oh, I'm a little bit quiet. Okay. Okay, so I'll try to speak up. So it's a pleasure to speak to you all today. And as Susan mentioned, we're going to be providing 3 research snapshots to give you an idea of some of the work that we've been doing in ONDRI Aim 4. And the first one is relating to COVID-19 and healthcare services for people with dementia in Ontario. So we all know from our daily lives that the COVID-19 pandemic has really disrupted the way we access healthcare services in our province, across the country, and globally. Now, the pandemic we know has placed an enormous strain on the healthcare system, and it's also changed the way that people with dementia and other health conditions interact with the healthcare system. And we know from previous work that people with dementia can be more vulnerable to disruptions in important healthcare services like home care services. So in this first study, which is shown on the right-hand side here, we investigated how the pandemic impacted the delivery of publicly funded at-home home care services, including support for personal support, nursing services, and services for therapies like physiotherapy and occupational therapy. So overall, we found that home care visits for personal care during the pandemic for people with dementia declined by 16% at the lowest point during the pandemic, but actually rebounded during the fall. So you can see that by the shape of the graph here that we're showing. In the three graphs, we've sort of separated these trends by different groups of people with dementia. So we've shown people living in rural and urban areas on the left-hand side, people of different sex, so males and females in the middle, and people residing in different levels of income neighborhoods shown on the right-hand side. So what we found was that people living in rural areas generally exhibited a slightly larger decline in home care services for personal care during the pandemic than people who were living in urban areas. We found that men and women had similar declines in home care service use during the pandemic, and those living in the highest income neighborhoods actually had a larger initial decline. The good news is that the home care services relatively quickly rebounded to what they were historically. So the period of a low level of home care support was relatively short during the pandemic. But of course, this still raises important concerns for people living with dementia and their care partners. So next, during the COVID-19 pandemic, we also wanted to examine how people with dementia interacted with other healthcare services. So things like emergency medical services, so ER visits, as well as hospitalizations. And we know that hospitals really play an important role in providing care for people with dementia, so this was important to look at. So we asked the question, how big of an impact did the pandemic have on the use of these healthcare services? And we compared patterns in three different patient groups. So we compared them in people with dementia, people with Parkinson's disease, and older adults who were age 65 and older who weren't living with these conditions. And what did we find? Well, what we found was overall there were declines in many of the healthcare services that we examined. So here you can see the rates of emergency department visits for people with dementia on the left-hand side, Parkinson's disease in the middle, and older adults on the right-hand side. So we found that overall there was a substantial decline in the rate of emergency department visits, ranging from 55 to 60%, depending on the group we looked at. And this raises important concerns in terms of care that may not have been received, urgent care that may not have been received because of fears of presenting to the emergency department due to infection and other issues. The rates did rebound, however, by the end of this study period, which was towards the end of September. So next we looked at family physician visits during the COVID-19 pandemic, and I'll walk you through how to interpret this graph here. If we look at the graph here, we can see the total number of visits during the 2020 year, which is shown by this dark line, solid line here, and a dashed line that's in lighter blue indicates the rate in 2019 for a comparison. So overall, this white space here, you can see in the dementia graph, in the Parkinson's graph, and the older adult graph, indicates that there was a decline in the rate of family physician visits overall. But what we found was there was an interesting pattern when we looked at virtual visits versus in-person visits. So we can see the virtual visits are shown by the darker gray here, and the lighter gray indicates in-person visits. So at the start of the COVID-19 pandemic, which is this orange line here, we saw that across all groups, there was actually a very rapid shift to virtual care. And this is showing virtual family physician care. In-person care, of course, dropped, but predominantly virtual care sort of took its place, and some of the rates even increased to higher than historical levels by the end of the study period. So what does this indicate? So this indicates that this is a potential success of our health system in adapting to the COVID-19 pandemic, in that we were able to maintain this vital family physician support using a different means, using virtual care. And we'll come back to that a little bit at the end as we have some questions for you if there's time. All right, so that was our first snapshot really focusing on COVID-19. And as Susan alluded to, there's also some important work that we've undertaken looking at how dementia develops along with other conditions that people with dementia might have. So we know that people with dementia often don't just have one chronic condition. So they may have dementia, as Susan mentioned, they may have hypertension or diabetes or Parkinson's disease. And in this particular study, we wanted to understand, how do these diseases develop? Do they develop before or after the dementia diagnosis? And how does the development of dementia influence the risk of subsequent diseases? So in this study, we looked at over 5 million Ontarians who were aged 40 to 85 years in 2002, and we followed them for up to 14 years to understand this pattern of neurological and psychiatric conditions. So in this snapshot, we looked at the relationship between the timing of a dementia diagnosis, which is shown on the left-hand side here, and the association with a mood or anxiety disorder after a dementia diagnosis. So what did we find? Well, overall, we can tell from the position of these dots, which indicate an increased rate of mood and anxiety disorder, the further right they are, we saw that within the first 6 months of someone having a dementia diagnosis, their rate of developing a mood or anxiety disorder was very, very high compared to people who did not have a history of dementia. And we saw that this relationship was actually sustained across different time periods since the dementia diagnosis. So what does this mean? So this indicates that mood and anxiety disorder is a really important co-occurring condition in people with dementia, and particularly around the time of dementia diagnosis. And providers should work to provide care for people with dementia to address these mental health concerns. And in a similar snapshot, we also examined the relationship between dementia, previous dementia, and the rate of being diagnosed with a stroke. And similarly, we found that there was an increased rate of stroke in the shorter time period following a dementia diagnosis. And this indicates that stroke and dementia likely have shared risk factors like cardiovascular risk factors, and patients should be managed in order to control these risk factors to reduce the risk of further health outcomes. Now, in our third research snapshot, we looked at sex differences in the use of antipsychotic and benzodiazepine medications. And these are medications that are often used off-label to treat the neuropsychiatric and behavioral symptoms of dementia. And we looked at these in a long-term care home population. So we know that the use of these medications is common in people with dementia, but it's not without risks. Previous studies have shown that these medications have been associated with poor health outcomes like falls, stroke, pneumonia, increased cognitive decline, and mortality. And these medications are sometimes known as potentially inappropriate medications because clinical guidelines often recommend not using these in people with dementia for the reasons that I've mentioned. So we know that men and women who have dementia can have differences in their psychosocial symptoms of dementia. Men may be more likely to exhibit challenging behaviors, and women may be more likely to have anxiety and depression, for instance. So we wanted to investigate whether the patterns of the use of these medications was different between men and women. So overall, we found when we looked at people who were newly admitted to a long-term care home who had dementia, we found that men were about 27% more likely than women to start an antipsychotic in the 180 days following long-term care admission, while women were less likely to stop an antipsychotic, and they were also less likely to stop a benzodiazepine medication. So overall, women were less likely to experience discontinuation or stopping of these medications. So overall, these findings indicate that antipsychotics and benzodiazepines are being used differently to treat the symptoms of dementia in men and women. And as we know the use of these medications can be risky, it's important to further understand factors behind their use and to avoid their use where possible. So what do we take from this in terms of how does our research inform what we can understand about population health for people with dementia? Well, to summarize, in our COVID-19 work, we showed that there was a large decline in health services for people living with dementia in Ontario during the pandemic. And this observed decline can have negative impacts in terms of the future long-term health outcomes for people with dementia. And this is important to assess in future work. For our dementia and psychiatric comorbidity study, we showed that people with dementia were at an increased risk of developing other disorders like mood and anxiety disorder and stroke. And it's important to recognize that these conditions can be treated and can help to improve health outcomes with appropriate management and health system planning. And finally, for our sex differences study, we found that men and women who were newly admitted to a long-term care home experienced different patterns of starting and stopping medications. And these medications should be regularly reviewed and acknowledge that there may be potential sex differences in their use. So coming back to the idea of HANDS Ontario, so how will the ICES or health administrative data be used? Well, it's going to be talked about next in greater detail, but we'll give you a bit of a snapshot here. So data from the HANDS Ontario participants, who are shown here in orange, will be linked using those anonymized health identifiers that Susan alluded to better understand health services use and neurodegenerative diseases and to look for long-term outcomes in this patient population. So by looking at the health administrative data, we can understand what someone's comorbidities or prior healthcare use was prior to their dementia, and we can also follow them longer term to understand how they interact with the healthcare system and whether, for instance, they're admitted to a long-term care home. So we'd like to thank you so much for attending today, and we're happy to answer any questions that you may have, or feel free to reach out to us at the email addresses provided. I know we are a little bit short on time, but we'll just leave you with a few questions to mull, and you can write in the chat box if you're able to. We're curious about your experience during the COVID-19 pandemic. Have you used virtual care? What was your experience? And any other suggestions you might have for us. So thank you so much.
And feel free to reach out to us outside of the
Yes.
Zoom forum too, if you have other thoughtful answers to these questions too.
Absolutely.
Thank you all very much.
Absolutely.